Hey guys, welcome to the channel. Today we're going to start doing something new. If you like it, I will keep it up. I wanted to start doing some videos going over just basic neuro stuff. All my content is going to go off of the content outline for the ABPN neurology board exam. So I'm just looking at the content outline and then I'm going to go through it, go through some topics with some high-yield points that I think are really important, just not only for clinical practice, but also for test taking. So the first thing on the content outline, if you look at it, is the headache section, which definitely is probably one of my best sections. It's not that much percentage. I think just looking at it now, I think it's like 4 to 6% of the exam is headache and pain disorders. So it's not that much, but obviously 4 and 6% can make a huge difference when you're trying to pass this test. So I wanted to talk today about migraine and migraine with aura. We can touch on a little bit of the high-yield pharmacology too. Since I do this every day, I can just spit off the high-yield information. And then we'll kind of work our way through. Maybe the next video I'll do some of the other primary headache disorders and then some of the secondary headache disorders. I wrote some notes, so I'm just going to peek down at those every once in a while and read them. But all this information, so for headache and facial pain, if you want information for the board exam and what's important, you can go to the ICHD3, so that's the International Classification of Headache Disorders, 3rd edition. You can just type that in on Google and that will give you what headache specialists use to basically put these headache disorders in boxes. In my practice, that's what I do. If I'm unsure, this is like a really good guide. So first topic I wanted to talk about would just be migraine. That's migraine without aura. So these are patients that are coming in and they're telling you they're not having any aura symptoms. We'll talk about aura in a second. In order to fulfill the diagnostic criteria for migraine without aura, you're going to need at least 5 attacks to fulfill this diagnostic criteria. So if someone had 2 of these events, doesn't fulfill it. You need 5 attacks to diagnose migraine. So remember that's important for the boards. Maybe they'll try to trick you with 2 attacks in a patient, and we can't definitively call that migraine without aura. The duration. So usually the duration is about 4 to 72 hours is the duration that the patient has to experience the migraine. You're going to need at least 2 of the 4 to diagnose migraine. So it has to either be unilateral, like a pulsating quality, moderate to severe in intensity, or aggravated by or causing avoidance of physical activity. So you need 2 of the 4 of those. I mean, most patients are usually meeting that criteria just like they say, hey, it's one side of my head and it's pulsing. Okay, they meet the criteria. Or it's one side of my head and it's moderate in intensity. Okay, they're meeting that criteria. This isn't necessarily for the purpose of the board exams, but just in general, it doesn't have to be unilateral. I think that's a misconception that even in neurology residency, I feel like we think about that, it has to just be unilateral. And that's totally not the case. Patients can present with migraine that's bilateral. This is another point in the migraine without aura where you can kind of get tripped up. So you need at least one of the following. So it's nausea or vomiting. So nausea or vomiting. So if you have nausea, that meets criteria. If you have vomiting, that meets criteria, so it's or, right? But there's photo and photophobia. So you need, photophobia and phonophobia. So if you have one of those and no nausea or vomiting, you're in the probable migraine category. You're not in, this is definitively migraine without aura. Let's talk about aura, because I think aura is pretty interesting. So aura needs to be fully reversible. If it's not fully reversible, then you're not going to be thinking about aura. You're going to go down that other differential diagnosis of, is this a seizure? What is a stroke? What's going on? This has to be fully reversible. There's different types of aura. Most common is visual aura. So when patients, this is the classic, you see the scintillating scotoma in the visual field, that is visual aura. And if you have the patient close an eye, it should be in both eyes. They should see the aura in one half of their world. There's also patients that have a sensory aura, so they'll describe how they feel this like tingling sensation going up their arm, maybe into their face. That's a sensory aura. You can have people with having speech and language issues, so like an aphasia. You can have motor symptoms like weakness. Some people have brainstem symptoms, and retinal, which is a whole nother topic of having a retinal aura. In order to diagnose migraine with aura, you need 3 out of the 6, right? So at least one symptom spreads greater than or equal to 5 minutes. So usually when I have patients in clinic and they're talking about aura, when I ask them, how long is it? How long is the aura lasting? And they're like, okay, 15 minutes. So that makes criteria. That's 1 of 3 of the 6. And then, or 2 or more aura types occur in succession. So that could be where they have visual symptoms and then they have sensory symptoms. That could be another example, and that's also 1 of the 6. Duration's typically 5 to 60 minutes. So like I mentioned before, so if you're like at 15 minutes, that's meeting the first criteria of aura, and this third one where it has to be between 5 and 60 minutes. So one symptom is a unilateral symptom. At least one aura symptom is considered positive. So that could be like the tingling sensation, that's considered a positive symptom. Patients, if they have aura, usually, but not always, but usually, for the purposes of the board exam, it's going to be followed by a headache within 60 minutes. And like I said, all this information is taken right off the ICH-D3. This is what I'm assuming is going to be the main bulk of how things are tested, because this is just the diagnostic criteria that we're using in headache disorders. On the content outline, if you look at it, it does not mention anything specifically under primary headache disorders. It doesn't mention treatment, but just something to know in general and in training and just for your own purposes and for the test, what are our primary treatments? So when people come in and you diagnose migraine, there's certain treatments, right? We have acute treatments and we have preventative treatments. So for acute treatments, we know we're using the triptans. But let's talk, and the new GPANs, which are a whole nother story, and we'll talk about those later. But let's talk about preventative treatments for the purposes of this video. So when someone comes to me and they say, I diagnose them with migraine, some of the first line preventative treatments that we use would be 1, a TCA, or a beta blocker, or topiramate. Those are the 3 that are used. Things will change in time, but for insurance purposes, for just in general, that's typically what we go for. Things to know about each of those drugs. The most important thing that they're probably going to ask about, because it's just important in clinical practice, would be side effects, right? First thing for the TCAs, you probably don't want to give that on someone that will have weight gain, right? You don't want to, that can cause weight gain. Probably also don't want to give that to someone that's elderly, right? So we would avoid the TCAs in elderly patients and those that we don't want to gain weight. Propranolol. If you have someone coming in that's a marathon runner and they have migraine, you're probably going to want to avoid propranolol, right? Because they can cause exercise intolerance. Another big one, which you have to ask, right, with beta blockers, that can worsen asthma. So we have to make sure that we're not giving propranolol to patients with asthma. For topiramate, right? Tons of side effects, right? I mean, one of the things it can do is cause cognitive issues. So people say, hey, I have trouble getting the words out. If in the question stem it talks about kidney stones, we cannot give topiramate. And another thing that is important to ask and important to know, topiramate can cause acute angle closure glaucoma. So that's something that you really want to think about. And if someone was started on topiramate and then they're calling the clinic and they're saying like, my eye is really hurting me, we have to worry that's a side effect that they've experienced. Other medications that can be used for migraine prevention would be things like atogepant. That is something that can be used daily for migraine prevention. There's another medication called rimegepant. You'll know the brand names, but that can be used in an every other day fashion for migraine prevention. And then we know that there are CGRP monoclonal antibodies that can also be used for migraine prevention. So those are the bulk of it. Just know a couple things about the CGRP monoclonal antibodies. One of the major side effects for some patients could be constipation. So if you have a patient that's very prone to, bowel obstructions, you'd want to avoid the monoclonal antibodies. Monoclonal antibodies can also increase hypertension. That's something to keep in mind. And the monoclonal antibodies can also worsen Raynaud's phenomenon. So if you have a patient that has severe Raynaud's phenomenon, you're not going to want to use the CGRP monoclonal antibodies. So that's just a quick breakdown of migraine, migraine with aura, and the preventative options that we have, and what I think is pretty high yield for clinical practice and also for test taking purposes. Let me know if you like these videos, because I can continue them. I don't have to. I feel like it's just a helpful way for people to get high yield neurology content.